Hey guys, Larissa here. I am getting ready to go through a basic fetal heart rate video. So probably one of the more complicated videos that I'll post, but this is something that labor nurses do literally every time they're doing labor, is they have a mom on a monitor and they're tracking it and they're watching baby's heart rate. So sort of as a disclaimer, you don't need to know all of this stuff. This isn't something that you need to be looking for during labor, but I think it's important that you understand what we are looking for so that you can kind of see the obvious dips on the heart rate and the things that might concern us, and that's the reason why we're doing what we're doing. So in a different video, I'll cover interventions, meaning the things that the nurses do when the heart rate is dropping low of baby. So, I mean, mom's heart rate we track, but it's really babies that I'm talking about. And then, but in this video, I'm going to focus on what we're looking for on that strip when we're monitoring you. So it's going to be a little complicated. I'm going to include videos, which is why I have this space off here to the side so that I can kind of bring those in so you can see examples. Again, this is what we go to school for. This is what we study for. So this isn't anything that you need to memorize. I just think it's nice to know and know that it's okay for baby to have dips and it doesn't have to be concerning, but the repeated dips in the heart and things like that can be of some concern, but that's why we monitor it. So always my little disclaimer, I'm not a doctor, I don't diagnose, I don't prescribe. My point is to educate you, so I hope that this kind of helps. So fetal heart rate monitoring, here we go. So you'll see on a strip, there's a top portion and a bottom portion. Top portion is going to be the heart rate of the baby. Bottom portion are those contractions. I discussed this a little bit in my NST video, my non-stress test video. So top line will usually only have one line for the heart rate. If you see two, it can mean that there are twins, or it can mean that mom's heart rate is also being monitored as well. Kind of depends on the hospital, but that's usually, if you see two, those would be your two reasons. So I'm going to go through each kind of piece as we go. So baseline for a heart rate, what we want to see is between 110 and 160. Now, the heart rate can vary and go up and down more or less, but if you see a zigzag line, if you were to draw a line sort of down the middle, we want to see it between 110 and 160. It's okay if it's sometimes a little higher. It's okay if it's sometimes a little lower, but that's something that we're watching. We'll know when you're admitted what baby's baseline has been, so then we can watch if it increases. So if you start at 110 and baby's baseline is 110 and then creeps to 160, that's a whole change of 50 beats for a baseline. So that's something that we're watching. But a regular, normal baby heart rate baseline is between 110 and 160, much higher than ours. In adults is 50 to 90, pain increases it and all that good stuff. So next thing that we're going to talk about on a baby's heart rate is the variability. So this is how much the heart rate varies, basically this up and down kind of zigzag pattern that you'll see. We do not want baby to have a flat line. That is not what we're looking for. We want baby's heart rate to vary. That's a great thing. So if it's like 160, 165, 155, 154, and it just keeps 151 and it keeps bouncing, it's great. That's what we expect. That's what we know will probably happen if baby's doing well and awake up in there. So moderate variability, which is the gold standard, we love that, is it varies between 6 to 25 beats. So it can vary by that much. It's great. Normal, great. Minimal variability is 1 to 6. So you're like basically right under that range, but not 0. That can also be fine. Just something that we notice. So minimal variability, moderate variability, and then marked variability is greater than 25. If there are periods of that, it's okay. We don't want to see that the whole time. That means baby's really jumping around there. So just something we're looking for. Minimal, moderate, or marked. Again, like I said, if there is absolutely no change in the baseline, that's absent, which makes sense. So absent variability, not a great sign. We would really like to see baby have some variability. So that's something we're looking for as well. So we've gone over baseline, we've gone over variability. Next thing we'll go over is accelerations. So accelerations are the rise in the heart rate, those mountains that we talked about. Those are wonderful. We love accelerations. We love to see baby having a little jump in the heart rate. Great. It doesn't have to be related to a contraction. It can happen whenever. It can be. It doesn't have to be. Those are great. We love those. Lots of accelerations, okay? Next is our not so great, but doesn't have to be a bad thing, decelerations. So decelerations, there are lots of different forms. In school, we learned this acronym called VEAL-CHOP. If you really want to know it, you can know it, but I'll explain it. So different decelerations and what they mean. I'll like put the little acronym at the end and include it in the notes below because it's great and that's how I still remember it sometimes. So variable decelerations. Variable decelerations are a sharp drop. So if you have a baseline that's going, you'll see a stark drop that looks like a V or it can look like a W. So those are called variables. That stands for cord compression. So if you see the word VEAL next to the word CHOP, the V and the C go together. So variables, cord compression. Now it means exactly what it means. Baby's cord is being squeezed. That can be positional, that can be baby's arm on it, that can be baby squeezing something. I mean, we don't know, we can't see inside. So that doesn't have to be a big concern. It just depends how low it drops, how often it's happening. And those are things you don't need to be worried about, but those are things that we're looking for is that variable deceleration, how low it's going to go and how often it's going to happen. And it means that there's a cord being compressed somewhere, which is normal because the cord is floating wherever it wants around baby. So the next one are on that little acronym is the VEAL. So it's an E. E's are for early accelerations. So those you see with contractions, a contraction does this little incline and then a early does a decline with it. So it's like a hill and a valley are connected. So you see this like, whoo, if that makes sense. I'll put up a picture so if my hands don't make sense. So that means that the head is being compressed, which is also normal because the head should be coming down during labor. So earlies are okay. They don't mean something bad. It just means the head's being compressed and we expect that to happen. So earlies are the valley with the hill and they'll be correlated together, okay? It's more gradual. So we've had variables, we've had earlies. We already talked about accelerations. That's what the A stands for. And then L is late. So lates are not super great. They can happen, but we would rather them not if we can control it. Lates are when you see a contraction and then the deceleration happens after the contraction. It shows us there's placental insufficiency, which is kind of a big fancy way to say baby's not getting the oxygen supply that baby needs. Again, there are ways to fix this and it can easily be corrected, and other times the baby is just not having it and there's nothing that we can do from the outside via mom to help the baby. So we've had variables, earlies, accelerations is the A and the VEAL, and then the lates. Another one that's kind of a side one is called a prolonged deceleration, which means it happens for greater than 2 minutes. You would see the nurse come in the room, change like the patient's position, maybe give them fluid. Again, I'll go over those more in an intervention video. And then if that, sometimes it resolves and sometimes it doesn't. Sometimes it takes a while. So, I mean, you can have a 2 to 6 minute deceleration. It just depends on the baby. Those aren't great. They're kind of concerning. It's nice when baby can correct it itself, but usually the nurse is already in there doing something because 2 minutes is quite a decent amount of time for the heart rate to kind of dip. Again, we just don't want the heart rate to dip that much. It's not a great sign. We want baby to be able to maintain their reserve and their heart rate up there. Okay, so we've talked through baseline, variability, accelerations, decelerations. I'm flipping my sheet over here so that I don't miss anything. So now I'm going to vaguely explain what these categories that have been formed, and that's how the nurses are communicating with the doctors. It's difficult because categories, there's only three. I think most of us would love for there to be more categories, but we don't come up with them. So, category 1, great strip. This is when we're like, baby looks great, category 1 strip, no problems, it's great. Category 1 means that the baseline's between 110 and 160. Go figure, right? We talk about that all the time. It has moderate variability, like we talked about before. There can be early decelerations, which are the valley with the hill, and there can be accelerations, but there don't have to be. So there can be early decelerations, there can or cannot be accelerations in general, but you need a baseline of 110 to 160 and moderate variability. It's a great strip, no problems. We cannot see any other decelerations. It would not be considered in category 1 strip. So that's category 1. I'm going to tell you category 3 because category 2 is literally everything else. So you can see why maybe we don't like the category all the time. So category 3, this is when the plan of care is changing. Something is going to change because this strip is not beautiful. This baby is having limited reserve and something has to change, especially if we're not close to delivering. Again, not my call, just something I would call about and most nurses would call about, okay? Category 3 strip. This means that the variability is absent. It's that straight line like we talked about earlier. And there are reoccurring lates and variables and prolonged decels, meaning that they happen more than 50% of the time. They're happening over and over and over again. Basically, this baby is distressed and ready to come out, which can happen at the end of labor, but it's something that we have to watch for and notify the doctor of. Another thing, just an FYI, you're not going to see this very much. I have not seen this yet. Practicing, there's a pattern called a sinusoidal pattern of a baby's heart rate. That is a pretty scary pattern that means the baby needs help. I'll pop it up here on the screen so you can see it. It sort of just looks like a wave that's continuous and never stops. There are things called pseudo-sinusoidal, meaning that they appear to be sinusoidal, but they aren't. Again, your nurse is going to know, especially if they've been monitoring you, if baby's in a sinusoidal pattern, or if you're not, you're going to have other things associated. But I just want you to know that that is a category 3 strip as well. So I've gone over category 1, I've gone over category 2, and now we're in this category, I've gone over category 1, category 3, and now we're in the category 2. Category 2 is literally everything else. So when you have some variable decelerations, when you have some late, when you have minimal variability, but no deceleration. So it's kind of this wide range of babies fine and category 2 strips are totally normal and pretty okay. But it's up to us and the doctor to kind of talk about and say, I know we're category 2, we're not category 3, but I'm noticing this trend or I'm seeing this, and that is up to us. But I just want you to know, if your nurse or your doctor uses that language, that's why. You have category 1, which is a wonderful, sublime strip. You have a category 2, which is, yeah, we're kind of bouncing. It's okay to have a category 2. There are worse category 2s than some other category 2s because it's such a big, giant grouping of strips. And then you have the category 3, which is plan of care will probably change and the doctor is going to make some sort of call. Again, depends on the doctor and it depends where you're at in delivery and labor and all that good stuff. So there are all your strips. Again, this is a huge crash course. I just want you to understand why we monitor, and especially if we are inducing your labor, the medications that the doctor is prescribing and that you are taking are going to affect baby's heart rate. They don't always, but they can, and so that's why you're on a monitor, and that's why the nurses are there to monitor baby and to be able to make changes so that maybe the medication isn't going in as quickly, or maybe we're changing a position because we're laying on baby's cord funny and we have Pitocin going and we don't want it to affect baby as much, so we change your position. So I just want you to understand that those are the strips and the weird things we're looking for. And so when it looks like your labor nurse maybe isn't doing anything, it's because she's watching your strip. Because there's lots of strip watching, and we have to be very careful as we watch baby, because the only way that we can help baby is by watching a strip, because we don't know what's going on internally except for that strip. It's the only way for us to see an active picture of our other patient, and our other patient is inside of you. So the last thing I wanted to talk through is that toco, which is the other belt around your abdomen that's measuring the contractions. So there are external monitors and internal monitors. The majority of what I've spoken about are external monitors. Those are the things that measure from the outside of your belly, the contractions and the heart rate. Internal monitors go through the vagina, and they either touch the baby's head or they sit kind of up in the vagina. So again, I'm not speaking on those right now. I'm only going to speak to external monitors. I'll have different videos about internal monitors. But external monitors, especially the toco, which measures that uterine contraction, as I've said before, it doesn't measure the strength. It only measures how often and how long the contractions are. So when a nurse is seeing how often you're contracting, we're looking for you to contract every 2 to 3 minutes when you're in labor. And we usually like the contractions to last like 60 to 90 seconds, more or less. What we have to do in regards to our assessment is palpate, meaning touch your belly, and that tells us how strong your contractions are. So kind of a cool trick that you might, want to know is when we're looking, they're mild, moderate, or strong. So mild is if you take your finger and you touch your nose. So this is what the tip of where your belly is hardening, this is what it'd feel like. This is mild. Right down here is moderate, and this is strong. So you can feel that like here, there's really no give back, and that's when we know the contractions are strong, and we'd feel that on the top of that abdomen. This right here is that mild, so still kind of bouncy and not that strong. And then down here is moderate, meaning, yeah, they're strong, but it's kind of easy to push through. So I don't know, something for you to test out, especially for those of you having those like give and take contractions every once in a while, for you to feel your tummy and kind of know. But again, that's what the nurse is looking for in regards to the toco or the contractions, is they're looking for how often and how long are they lasting, and then they will feel your tummy to feel how strong they are. Pretty subjective, I understand that, but sometimes that's all you need. If the woman's contracting every 2 to 3 minutes and huffing and puffing, we know that they're pretty effective. I hope that this helped. This is a really complicated subject. Nurses go and take classes on these, and we take like beginner and then like intermediate, and so we continue to take classes and educate ourselves on fetal heart rate monitoring. And I think it's going to continue to change as I practice as a nurse. I think it's going to continue to change the categories and how we communicate effectively with the doctors. You'll hear us when we call, especially with the category 2, we usually have to throw in what decelerations we've been seeing and how often they've been happening, because category 2 doesn't clarify those things. So it's really up to the communication between us. Again, a lot of doctors actually have access to these, to the different strips and stuff like that in their office or at home. So it's kind of a nice thing. So if the nurse were to call in the middle of the night and say, hey, I'm seeing something that I don't think looks right, I've done my interventions, baby's just kind of looking, they can sometimes pull those up. And a lot of times they will, which is great, just to get a second eye on it. Most of us nurses are watching each other's strips anyway, so you're never really alone. But just kind of a neat thing. It's, again, like I said, it's our only way to get a picture of what your baby is doing inside. And so it's super, super important. So I apologize in advance if we're constantly trying to put you back on the monitor, but our second patient is in there, and this is how we watch them. So again, feel free to add questions, put your concerns down below, and I'll try to answer them to the best of my ability. Again, I can't tell you what a doctor would do. I don't do the diagnosing, and I don't decide the plan of care. I just assess and report off. That's my job, but I'm here to educate you just like I would if I was your nurse in the hospital. So please feel free to like and subscribe. if these are helpful, and I'll continue to put more content out there and get that video out about the interventions that we do in order to help with those decelerations and things like that during labor. Great. Thank you guys.